Welcome to the deep dive. Today we're zeroing in on pneumonia. It's that common lung condition, but it can really range from just a bit of a nuisance to something quite serious.
That's right.
Think of this as your go-to guide. We want to get the most important info, keep it clear, keep it concise.
Exactly. Our mission is to dive into our notes here and pull out those essential nuggets, give you a really solid understanding, and maybe some memory tricks to help it stick.
Love a good memory trick. So, pneumonia. We've all heard of it, but what is it exactly?
Okay, so at its heart, it's an infection. It causes inflammation, specifically in the tiny air sacs in your lungs, the alveoli.
Right.
And that inflammation makes these sacs fill up with fluid, or sometimes pus. And that, makes it harder to breathe.
Okay, so it's not just one specific bug causing all this trouble.
No, definitely not. Pneumonia can be triggered by, well, a whole range of microorganisms, bacteria, viruses, even fungi sometimes, and other things too. And like you said, the severity is really a spectrum. It can be quite mild, something you recover from at home, or it can be severe, needing hospital care, and potentially even life-threatening.
And it can hit anyone, right? It's not just certain groups.
It can, yeah. People of all ages can get pneumonia, but the very young, the elderly, and anyone with a weakened immune system, they're definitely more vulnerable.
Okay.
The basic process, the mechanism, involves that inflammation in the lung tissue. Your immune system rushes in neutrophils, they're a type of white blood cell, and they infiltrate the air sacs.
And that causes the blockage?
Sort of. It leads to what we call consolidation. Think of it like the affected part of the lung becoming, well, less spongy and more solid because it's filled with all that inflammatory fluid and cells.
Got it. So let's break down the causes then. What are the main culprits?
We can group them nicely. Bacteria are a major player. Streptococcus pneumonia, often called pneumococcus, that's the big one, responsible for maybe 80% of bacterial cases.
80%? Wow.
Yeah. Then there's Haemophilus influenza, which we often see in people who already have COPD, chronic obstructive pulmonary disease. Other key bacteria include Mycoplasma pneumonia, sometimes called walking pneumonia, and Legionella pneumophila, which causes Legionnaire's disease.
Right.
Actually, there's a memory tip for those main bacterial ones. Some hot moms love Legos.
Okay. Some hot moms love Legos.
Yep. Streptococcus, Haemophilus, Mycoplasma, Legionella.
That's brilliant. Okay, I'll remember that. What about viruses? We hear so much about respiratory viruses.
Absolutely. Viruses are common causes too. Think influenza viruses, the flu, RSV, which is respiratory syncytial virus, especially in kids, and of course, coronaviruses.
Makes sense.
Fungal pneumonia is less common in generally healthy people. It tends to affect those with weakened immune systems more. Mnemocystis jirovecii is a classic example, often seen in HIV/AIDS patients before effective treatment.
Right.
And then there's aspiration pneumonia. That happens when you accidentally inhale something foreign into your lungs, like food, drink, or even stomach contents.
Oh, okay. I've also heard terms like CAP and HAP, community acquired.
Yes, good point. CAP stands for community-acquired pneumonia. That just means you picked up the infection outside of a hospital or healthcare setting.
Right, just out in the community.
Exactly. And HAP is hospital-acquired pneumonia. That develops during or after a hospital stay. The bugs involved can be different, often more resistant, and so the treatment might change too.
Okay, that distinction is important. So, thinking about risk factors, who is most likely to actually get pneumonia?
Well, several things increase your risk. Age is a big one. Infants, young kids, and older adults are more susceptible.
Okay.
Lifestyle factors play a role too. Smoking is a major one, damages the lungs' defenses. Excessive alcohol use also weakens the immune system.
Right.
And interestingly, having a recent viral infection, like the flu, can actually make you more vulnerable to getting a secondary bacterial pneumonia. Your immune system is kind of distracted, you could say.
That makes sense.
Existing lung conditions are definitely risk factors. Things like asthma, COPD, bronchiectasis, cystic fibrosis, even lung cancer.
So pre-existing damage.
Exactly.
Right.
And anything that weakens the immune system is a major factor. HIV/AIDS, chemotherapy for cancer, medications after an organ transplant.
Got it.
Specific exposures matter too. For example, intravenous drug use is linked with a higher risk of Staphylococcus aureus pneumonia. And being hospitalized, as we mentioned with HAP, increases risk, often from gram-negative bacteria. Conditions that increase the chance of aspiration, like having impaired consciousness, maybe from a stroke, or certain neurological diseases or even problems swallowing, they raise the risk.
Okay.
And finally, other underlying medical conditions like diabetes mellitus and cardiovascular diseases also make people more prone to pneumonia.
So it's quite a wide range of things that can make someone more vulnerable. What's actually happening down in the lungs step by step when this infection takes hold?
Okay, the pathophysiology, let's walk through it.
Okay.
First, the microorganisms, bacteria, viruses, whatever, they manage to invade the lung tissue.
Step 1, invasion.
Right. Step 2, your immune system spots the invaders and mounts an inflammatory response. It sends immune cells to the site, releases chemicals.
Yeah,
This causes inflammation.
the body fighting back.
Exactly. But this inflammation also makes the tiny blood vessels in the lungs leakier. We call it increased permeability.
Okay, leaky vessels.
And because they're leaky, fluid, immune cells, debris, sometimes pus, starts accumulating in those tiny air sacs, the alveoli,
So they get clogged up.
pretty much.
Sure.
And that buildup directly interferes with the lung's main job,
Huh.
changing oxygen, carbon dioxide. Gas exchange is impaired.
Which leads to the symptoms.
Yes, that's when you start getting shortness of breath, maybe low oxygen levels. Then in some areas, the lung tissue can become quite dense and solid because of all this inflammation and fluid. That's the consolidation we talked about.
Right.
And all of this together manifests as the symptoms we associate with pneumonia. Fever, cough, chest pain, difficulty breathing, feeling really tired and unwell.
That paints a clear picture. Now, you mentioned community-acquired pneumonia, CAP, earlier. What's the key diagnostic feature for that?
Right. For CAP, the sort of defining feature doctors look for is a new shadow or opacity on a lung imaging test, usually a chest x-ray. It shows that area of infection or inflammation in the lung.
The consolidation.
Exactly.
Okay.
And crucially, there isn't another obvious explanation for it, like a tumor or something else.
Got it. And the usual suspects for CAP, microorganism-wise?
The most common ones are still Streptococcus pneumonia, often Staphylococcus aureus as well, Mycoplasma pneumonia, Haemophilus influenza, Chlamydophila pneumonia, and various respiratory viruses are definitely in the mix.
Okay.
And it's worth remembering, in maybe a quarter of CAP cases, it's not just one bug. It can be a mixed infection with multiple organisms involved.
Right, complicating things. Now, if someone comes in coughing, feeling rough, how do doctors distinguish pneumonia from other things that cause similar symptoms? What's on the differential diagnosis list?
That's a really important question in practice. Several conditions can look like pneumonia initially. Bronchitis, for instance, that's inflammation too, but mainly in the larger airways. The bronchi, not usually down in the air sacs.
Okay, different location.
Yes. Bronchiolitis is another that mainly affects infants and young children, involves the smallest airways, the bronchioles, and often causes wheezing.
Right.
Tuberculosis, TB, is a bacterial lung infection. It causes cough and fever, but often has other signs like night sweats and weight loss. Specific tests, like sputum analysis for the TD bacteria and characteristic X-ray findings, help confirm it.
Okay.
A pulmonary embolism, that's a blood clot in the lung artery, can cause sudden shortness of breath and chest pain, sometimes a cough too. But the onset is often more abrupt, and CT scans are key for diagnosis.
Very different cause.
Totally different. Lung cancer can present with a persistent cough, sometimes shortness of breath or weight loss. Imaging and potentially a biopsy are needed. Congestive heart failure can cause fluid to back up into the lungs, leading to breathlessness and sometimes a cough, but it's a heart problem, not an infection. An echocardiogram helps diagnose that.
Got it.
Even the flu can look very similar initially. Fever, cough, aches. But we have rapid flu tests that can help differentiate.
True.
Then you have chronic conditions like COPD. People with COPD often have a chronic cough, but spirometry lung function testing helps tell it apart from an acute pneumonia. Same with asthma, wheezing, and breathlessness are common. But it's an inflammatory condition of the airways with a different mechanism.
So careful assessment is needed. Thinking about the UK specifically, how big a problem is pneumonia here?
Oh, it's absolutely a significant health issue in the UK, a major cause of illness, hospital admissions, and unfortunately a significant cause of death as well. We definitely see more cases during the winter months. That's pretty typical for respiratory infections. And as we've discussed, it hits those higher risk groups harder, the elderly, people with chronic conditions.
And you mentioned some numbers earlier that really drive home the scale.
Yes, the figures are quite striking. Community-acquired pneumonia, CAP, affects somewhere between 0.5% and 1% of adults in the UK each year.
Okay.
When people go to their GP complaining of lower respiratory symptoms, like a chesty cough, CAP is diagnosed in about 5 to 12% of them.
All right.
And of those diagnosed, a substantial portion, somewhere between 22 and 42%, end up needing hospital admission.
That's a lot.
It is. And the mortality rate isn't insignificant, ranging from 5 to 14% overall for hospitalized patients.
Wow.
If someone becomes ill enough to need intensive care, the mortality risk jumps significantly, sometimes over 30%. And a really sobering statistic is that over half of all deaths related to pneumonia in the UK occur in people over the age of 84.
That's quite stark.
It is. In England alone, we're talking about roughly 100,000 hospital admissions for pneumonia every year, with most happening in autumn and winter.
So, really common and potentially very serious. What are the classic signs and symptoms people should be aware of?
Okay, clinical presentation, it can vary, but the common things to look out for are a cough. This might be dry, or it might produce sputum, which could be clear, yellow, green, or sometimes even rust-colored or blood-stained.
Okay.
Fever is very common, often accompanied by chills or shivering. Dyspnea, that's the medical term for shortness of breath.
Right.
Chest pain is also frequent, and it might be pleuritic, meaning it feels sharp and gets worse when you take a deep breath or cough.
Oh.
Yeah.
Okay.
And just generally feeling unwell, fatigue, malaise, just feeling wiped out.
Okay. And what might a doctor pick up on examination?
Well, listening to the chest with a stethoscope is key. They might hear abnormal breath sounds over the affected area, like bronchial breathing, which is a harsher sound, or crackles.
Uh-huh.
The respiratory rate is often increased breathing faster than normal. That's tachypnea. There might be other signs of systemic inflammation, like the fever we mentioned, or a fast heart rate, tachycardia. And measuring oxygen saturation with a pulse oximeter might show reduced levels of hypoxemia, indicating the lungs aren't getting enough oxygen into the blood.
Are there differences in how it presents, say, in kids versus older adults?
Yes, definitely. In really severe cases, in any age group, you might see confusion, cyanosis, that's a bluish tinge to the skin, lips or nail beds due to low oxygen, and signs of hemodynamic instability like dangerously low blood pressure.
Right, the really worrying signs.
Exactly. But in infants and young children, the symptoms can be quite nonspecific. They might just have a fever, a cough, be feeding poorly, seem really lethargic or irritable. Sometimes they might even complain of tummy pain.
Tricky to pin down sometimes.
It can be. And interestingly, in the elderly, the classic symptoms like high fever and a very productive cough might be less pronounced. They might mainly present with confusion, falls, general malaise, fatigue, loss of appetite, or muscle aches.
So it can be subtle.
It can. So when diagnosing, doctors look for those focal chest signs on examination, combined with the symptoms. Initially, vital signs like heart rate, breathing rate, and temperature might actually be normal, especially early on or in milder cases. But they often become abnormal as things progress.
Okay. So if pneumonia is suspected based on symptoms and examination, what tests are typically done to confirm it?
The cornerstone of diagnosis is usually the chest X-ray. That's what shows the infiltrates or consolidation in the lung tissue we've been talking about. It's really a hallmark finding.
The picture that confirms it.
Pretty much. Blood tests are also very important. A complete blood count, or CBC, often shows neutrophilia, a high level of neutrophil white blood cells, which is typical in bacterial infections.
Okay.
C-reactive protein, CRP, is another key blood test. It's a marker of inflammation, and it's usually elevated in pneumonia.
Right, I've heard of CRP.
There's also procalcitonin, another marker that can sometimes help assess how severe the infection is and potentially guide antibiotic use, though it's not used everywhere.
Okay. And what about figuring out the specific bug causing it?
Yeah, ideally you want to know the culprit. Microbiological analysis is used for that. This can involve collecting a sputum sample for culture if the patient is coughing productively. Sometimes a nasopharyngeal swab, like the ones used for COVID testing, can detect viruses or certain bacteria. In more severe cases, or if diagnosis is unclear, doctors might perform a bronchoalveolar lavage, or BAL. That involves putting a small scope into the lungs and washing out a sample of fluid to test.
More invasive, but gets a direct sample.
Exactly. The goal of all this is to identify the specific pathogen if possible, which can help tailor antibiotic treatment. And other assessments like arterial blood gas analysis might be done if someone is very breathless to get a precise measure of oxygen and carbon dioxide levels. Pulse oximetry, the little clip on the finger, gives a quick, non-invasive check of oxygen saturation.
Right. So once IRP is diagnosed, how do doctors decide who needs to be in hospital versus who can manage at home?
That's a really critical decision, and it's based on assessing the severity of the illness and the risk of complications. Doctors often use scoring systems to help guide this.
Okay.
A widely used one, recommended by INES in the UK, is the CRB-65 score. It's designed for assessment outside the hospital.
CRB-65, what does that stand for?
It looks at 4 simple factors. C is for confusion, specifically new onset confusion or disorientation. R is for respiratory rate, a rate of 30 breaths per minute or more. B is for blood pressure, low blood pressure, specifically systolic, less than 90 mmHg, or diastolic less than or equal to 60 mmHg. And 65 is for age, being 65 years or older.
Confusion, rate, blood pressure, 65.
Yep, exactly. Each factor scores 1 point. A score of 0 generally means low risk, and treatment at home can be considered.
Right.
A score of 1 or 2 indicates intermediate risk, and hospital assessment should be considered, especially with a score of 2. A score of 3 or 4 means high risk, and urgent hospital admission is usually recommended.
So it's a quick way to stratify risk.
It is. There's also a related score called CURB-65, often used in hospitals, which adds U for urea, a measure of kidney function from a blood test. It gives a bit more detail but requires a blood test.
Okay, CURB-65 includes urea. Good to know. So let's talk treatment. What's involved in managing pneumonia?
Right. Management. There are general measures and then specific treatments like antibiotics. General advice includes stopping smoking, obviously, getting plenty of rest, and drinking lots of fluids to stay hydrated.
The basics?
Yep. If oxygen levels are low, hypoxia, then supplemental oxygen is given. In very severe cases with respiratory failure, mechanical ventilation might be necessary.
Okay.
5E fluids might be needed if someone is dehydrated or can't drink enough. Pain relief is important too. For chest pain or general aches, simple things like paracetamol or ibuprofen often help. Stronger painkillers like opiates might be needed for severe pain, but they're used cautiously as they can suppress breathing. Sometimes nebulized saline is used to help loosen secretions and make it easier to cough them up, though the evidence for routine chest physiotherapy isn't always strong.
Okay. But the main treatment, especially if it's bacterial, is antibiotics, right?
Absolutely. Antibiotics are crucial for suspected bacterial pneumonia. Prompt treatment saves lives.
How is the specific antibiotic chosen?
Well, the choice depends on several things. The patient themselves, how severe the pneumonia is, whether it's community-acquired or hospital-acquired, and importantly, local patterns of antibiotic resistance.
Makes sense.
For low-severity CAP treated at home, the first choice is often a 5-day course of amoxicillin.
Okay.
If someone is allergic to penicillin, or if an atypical bacterium like Mycoplasma is suspected, alternatives like clarithromycin or doxycycline might be used. Erythromycin is another option, often preferred in pregnancy. For moderate to severe CAP needing hospital admission, the antibiotic choice might be similar initially, often amoxicillin, plus maybe clarithromycin if atypicals are suspected. For high-severity CAP, often managed in hospital, a broader spectrum combination is usually used, like colmoxiclav plus clarithromycin or erythromycin in pregnancy. These might be given intravenously at first, then switched to oral, typically for a total of 5 to 7 days, depending on response.
And the CRB-65 or CRB-65 score helps decide where treatment happens.
Exactly. It helps stratify risk and guides the decision about hospital admission. In primary care, using CRB-65, score 0, consider home treatment. Score 1 or 2, consider hospital assessment, especially score 2. Score 3 or 4, urgent hospital admission.
Okay.
Some GP practices might also use point-of-care CRP testing. If the CRP level is low, say 20 milligel, antibiotics might not be needed immediately. If it's intermediate, 2,100 milligel, maybe a delayed prescription. If it's high, 100 milligel, antibiotics are usually offered.
Using CLP to guide antibiotics.
Yes. In secondary care, using CRB-65, score 0 or 1 is low risk, consider home care. Score 2 is intermediate risk, usually hospital admission. Score 3 or more is high risk, hospital admission is definite, and intensive care assessment should be considered.
Got it. And in hospital, they might do more tests.
Yes. For intermediate or high-risk patients, further investigations like blood cultures, sputum cultures, and urinary antigen tests for specific bacteria like Pneumococcus and Legionella are often done. CRP levels might also be monitored to see how well the treatment is working.
Okay, that's comprehensive. What about when someone starts getting better? How long does recovery typically take?
That's important to manage expectations. Recovery takes time. Generally, the fever should settle within about a week of starting treatment.
Okay.
Chest pain and sputum production usually reduce significantly over about 4 weeks.
4 weeks.
The cough and any breathlessness tend to linger longer, but should be much better within about 6 weeks.
6 weeks for the cough.
Yeah. By 3 months, most symptoms should have resolved, although some fatigue can persist even then. For most people, it might take up to 6 months to feel completely back to their normal selves.
6 months. That's longer than people might think.
It often is. And a really crucial point, NICE recommends a repeat chest x-ray about 6 weeks after the clinical resolution of symptoms. This is to make sure the consolidation is cleared and, importantly, to rule out any underlying problem that might have been hidden by the pneumonia, like a lung tumor.
That follow-up X-ray is key then.
Absolutely vital. Discharge from hospital is usually considered when vital signs are stable, temperature is normal, oxygen isn't needed, and the person can eat and drink okay.
Makes sense. So what's the overall outlook, the prognosis, for someone with pneumonia? And can we prevent it?
Prognosis really varies. It depends heavily on the person's underlying health, their age, how severe the pneumonia was, and how quickly they received appropriate treatment. The good news is that most people with CAP respond well to antibiotics.
That's good.
But, as mortality stats show, severe cases, especially in those with other health problems, comorbidities, carry significant risks. Mortality rates, as we touched on, are generally low for those treated in the community, less than 1%, rise to about 5–10% for those admitted to a general hospital ward, but can be much higher, maybe 25% or more, for those needing mechanical ventilation in intensive care. Some types, like Legionella pneumonia, tend to be more severe.
Sobering. How about prevention?
Prevention is super important. Firstly, prompt diagnosis and treatment with antibiotics for bacterial pneumonia saves lives. Secondly, vaccination is key.
Which vaccines?
The influenza vaccine, the annual flu jab, helps prevent flu, which, as we know, can predispose to bacterial pneumonia, and the pneumococcal vaccine protects against Streptococcus pneumonia, the most common bacterial cause. This is particularly recommended for infants, older adults, and those in high-risk groups.
Right, flu jab and pneumococcal vaccine.
And thirdly, smoking cessation. Quitting smoking is one of the single best things you can do to reduce your risk of pneumonia and other respiratory infections.
Crucial lifestyle factor. Okay, lastly, what are the potential complications if pneumonia gets serious or isn't treated effectively?
Yeah, complications can unfortunately occur. These can range from issues within the lungs to problems affecting the whole body.
Okay.
Lung complications include respiratory failure, where the lungs can't provide enough oxygen or remove enough carbon dioxide. Sepsis is a major risk. That's a life-threatening condition where the body's response to infection damages its own tissues.
Very serious.
Yes. Lung abscesses can form. These are collections of pus within the lung tissue itself, more common with certain types of bacteria. Empyema can develop, that's pus collecting in the pleural space, the area between the lung and the chest wall. A pleural effusion is similar, but it's just fluid, not necessarily infected pus, building up in that space.
Effusion versus empyema. Got it.
Acute respiratory distress syndrome, or ARDS, is a severe form of lung injury leading to widespread inflammation and fluid buildup. And in the worst cases, pneumonia and sepsis can lead to multi-organ failure and, sadly, death. There are rarer complications too, like pneumatoceles, air-filled cysts in the lung, pneumothorax, collapsed lung, or even systemic spread, causing things like bloodstream infections, heart valve infections, endocarditis, or meningitis. Long-term, some people can develop post-infective bronchiectasis, which is permanent damage and widening of the airways, or just have an increased susceptibility to getting lung infections again. And severe pneumonia can sometimes cause acute kidney injury.
So a wide range of potential problems. This has been incredibly thorough. Thank you. Just to quickly recap the absolute key takeaways.
Here.
Pneumonia is an infection causing inflammation and fluid in the lungs' air sacs. It's caused by various bugs, mainly bacteria like Streptococcus pneumonia, and viruses. Risk factors are crucial age, smoking, weakened immunity, other health conditions.
Put that on.
Diagnosis usually relies on symptoms and that key chest X-ray finding. Treatment hinges on antibiotics for bacterial cases alongside supportive care. And prevention is vital. Think vaccines and quitting smoking.
Exactly. Understanding those core elements, causes, risks, diagnosis, treatment, prevention, that's really key for tackling pneumonia effectively.
Absolutely. For everyone listening who wants to really cement this knowledge or explore more revision resources, definitely check out pastthemsra.com and also freemsra.com.
Great resources.
Thanks so much for joining us for this deep dive into pneumonia.